Hello, everybody. My name is Jeff Antone, and I'm the Chief Dosimetrist in the Department of Radiation Medicine at Northwell Health in Long Island, New York. Today's talk is optimizing A values and priorities for effective head and neck treatment plans. And my goal today is to figure out ways how we can make it a little more easier to deal with complex cases. I use Eclipse treatment planning system, and I'll show you what I've experienced to help me along the way. Now, evaluating some plans, we are trying to tighten up the lowered isodose curves, and to do so, we use these good old push structures, or we crop our organs at risks to help minimize the dose while still keeping great coverage around the PTV. Some other planners create rings, or what they call shells, to help tighten up the lower isodose levels. Also in the examples, have you ever tried squeezing 20 gray line to help meet the mean parotid dose? You're trying to find wherever you can to achieve. But by doing so, you're making many dummy structures, and it can complicate things, and it's hard to manage and see which has more priority over others. And during the optimization process, the numbers keep climbing, and you keep on backtracking, creating more trials, and using more treatment plans, more MUs, taking a longer amount of time in order to get the objectives met. So today I'm going to talk about GUD and explain what is it and define the A values correlating with serial and parallel structures. Then I'll have a discussion and certain guidelines that I've used in the clinic for OARs. And so what is GUD? GUD defines as a generalized equivalent uniform dose. Now, for me to understand this, I had to grasp it because I have children and we used to watch Peppa Pig. And you want to look at it as this. How can I be healthier? How can I lower my cholesterol levels? So there's different ways of going about it. Can I go eat less carbs, more fruits? When you look at the biological effects of each one and summate them, you get this A value. So lower GUD defines an exact minimum uniform dose for the PTV. You're trying to push that line to meet the 100%. You're looking for that voxel to push. Likewise with target GUD, defines an exact equivalent uniform dose for the PTV, and it penalizes the cold spots. Upper GUD defines an exact equivalent maximum dose for organs at risk. So the higher the A value, it pushes on the max dose. And this is what I'll use on structures such as cord or brainstem. And again, with the lower value of the GUD, upper GUD, it pushes on the majority of the DVH. So figuring out which value, A value, correlates on which area of the curve that it'll help push. Chowever, what is a good range value to use since it's such a broad range? It goes from -40 to +40, and there's too many to choose from. Back when, at Eclipse, when you post-process things, it used to be 1 to 4 value. Currently, we're about up to 20 level values. So trying to figure out which one works. When you're looking at these alpha values, A1 is really the mean dose, while when you go to +40, it concentrates on the hot spots for the OARs, and you go more to the negative side, it concentrates more on the coverage of your target value. Here are some values from TG166 that you can use as reference. And I started off looking at parotid and cord to figure out what numbers work well, followed by the PTV. Here's some other values that they put as a parameter to use as reference, 0.5. So when you first look at your optimization and you click on the GUD, it defaults to 1. Nothing really changes here because it's using the same mean value, so that it doesn't really help, or I think as effective as it should be. So we went and got about 5 head and neck patients, hypopharynx, base of tongue, tonsil, nasopharynx, had bilateral targets, and it used simultaneous integrated boosts. 70 gray and 35 fractions, where 70 gray is red, 63 is blue, 5810 is yellow, and the PTV was cropped 3 millimeters from one another. The goal is to look at how we can minimize dose to the parodids, and in these scenarios, it ranged from 30% to 50% overlap. Now, you can still crop these structures from one another, but the effectiveness of using GOD is less prominent. So you can see on the top graph, when they're abutting each other, you can see which one's penalized and how it pushes your dose, whereas the graph on the right, where it's cropped 4 millimeters, you don't see much of a difference. So there's no sense of using GODs at that point. As far as normal tissue constraints, these are some of the things that I've seen in clinic where you want to have that fall off if you don't want to use the rings or the shells. And the distance from the border is about 1 to 2 millimeters. And you can also use automatic. It's just As far as the optimization goes, you want your starting ratios to be at 100% and your organs at risk to be a third of that. I defaulted mine to 150 because I was used to that with the old Eclipse planning station. So I did 1/3. So 50 was the upper limits for my organs at risk. If you go unilateral, you could start at half the value of priority for the PT. Some of the guidelines that we used were from Quantex constraints. There's paper involved where you're trying to see which mean dose we're looking for. So in this case, we're trying to aim the mean dose less than 25 gray, which will reduce the risk of xerostomia by less than 20%. And during the optimization, I tend to hold the values at MR level 2 or even at the end of level 1. This is where you have the most jumps during the arc, and this helps flatten it out. By the time it gets to MR level 3 or 4, it's tweaking at that point. So I try to do it at the beginning stages. So you can see here, as using different priority values, as you increase the priority, how much more you lose coverage on your PTV, but you spare more on your organs at risk. Using the target GUD, I was able to still minimize the parotid dose but maintain PTV coverage. And I'll get to the target GUD in a minute. So we like the coverage, but the MD still, as they're evaluating, wanted to make the mean dose 26, even though we saw that you had 20 gray squeezing pretty tight around these parotid doses. So where in the graph can I squeeze this? Because it looked pretty tight to me. And the mean dose was roughly 31 gray on both parotids. So after running many trials, we just noticed that if you use the A value of 1, it usually goes by the average dose. And anything past A level of 6 or 7, it definitely pushes the organs at risk at most, but it compromises your PTV structures. What I used, and I liked in my experience, is about 0.7 to help squeeze it optimally. That's the number I like to use. And if you're trying to squeeze the lower oistodose levels, such as a 20 gray line, I tend to use a 0.3. And even though you don't necessarily have to put a bunch of uppers, you could add another GUD. You shouldn't limit yourself to 1 or 2. It's okay to add an extra one, but you don't need to go as crazy. It just saves the time of adding a bunch of upper values and playing around with the priorities. So using GED values and the 0.3 A value, I was able to get something comparable to the parotid doses, or even better, without compromising coverage. Actually, with this case, I was able to get a little more coverage with my PTVs. As far as the spinal cord, you deal with max point doses. So we look at our Dmax, where 50 gray will represent a 0.2% chance of myelopathy, and up to 69 gray where you have 50% chance. And MAMI, they use about 1/3 going to 50 gray. However, when you're presenting this to attendings or a physics group, you notice that you can have a long tail and then your max point dose could be violated. But you have to keep in mind these are voxel doses. So you have to look at your CC volumes to make sure and kind of draw that line without having to go back into the plan and re-optimize. In this case, for that 30 gray line max, it was about 0.0009 cc's. So make sure when somebody's reviewing your plans to look at your volumes and voxels and don't get sold just on that max point. So using the GEUDs, I was able to push this max core dose and still maintain the coverage. My experience, I like to use either values of 10 or 15, and I try to keep it. As you can see, instead of using these optimized structures and GEU versus GUD, I was still able to maintain a homogeneous dose and squeeze out the lower isodose levels. Now moving on to target upper and lower GUDs, we're trying to establish how can we use these functions for our targets. It's a beautiful dance trying to balance these dose constraints. The goal in mind here is to have that vertical DVH, where you're trying to push that curve more of a straight line, 90-degree angle. So what I like to use is the target GUD. It penalizes the cold spots where you're kept on pushing your away Rs, but it still maintains your uniform. As far as lower GUDs, it penalizes the minimum dose and it tries to find that voxel, that 0.1%, to push it to get your 100% coverage and that target minimum to satisfy. Is that if you use the lower GUD, in my experience, you will get that dose coverage. However, when you evaluate your plans through your slices, you can notice that you lose out on the conformity and you see dose spillage and more hotspots. We must make sure that when you start to optimize, you shouldn't have any placeholding when you start the software program. What happens is that it goes crazy in the background, and I don't think we're trying to plan to 297,000 centigrade. So make sure you can put at least a value of 1 in there to just make it think as opposed to. As you can see here again, it just shows that when you don't enter a number, it'll say that it's trying to push the dose to 500,000 centigrade. As far as upper GEDs for PTV, the higher A value affects the max point dose, hence inhomogeneity. So we're trying to look at how we can limit the hotspots. In this scenario, where the blue is 6,300 centigrade, I wanted to limit the 105 and 106 hotspots. Same thing with the yellow, which went to 5810. So it can be accomplished when you're using upper GUDs as well for target structures. You just have to make sure you have a nice balance when you're optimizing. The one on the left shows where it was originally, and the one on the right shows how the dose was minimized, the hotspots. Now, as far as discussions goes, you're pushing all these structures together, and dose has to go somewhere. You're squeezing a balloon, and it's going to go, in this scenario, they connected between the spinal cord and constrictors since I was pushing the larynx and other OARs. Another aspect is if there is no contours drawn, such as the oral cavity, you can't really have anything to push to make it tighter. Contours, if they're not congruent and they're very choppy, it will be hard to optimize as well. So make sure you review your contours. You can plan with GUDs without cropping, but it becomes a little bit more homogeneous as far as my experience goes, and you probably need to renormalize a little bit more. And if you were to crop your PTV without any buffer, I tend to see that you lose coverage on your supinf interface between your 2 to 3 dose values. So here's an example of a plan that I was able to push. And you want to evaluate which structures you need to push because, again, dose has to go somewhere. In this case, I wanted to make sure that my spinal cord and my parotids were much lower. However, I compromised on my submandibular glands, but my brainstem was spared as well. And I was still able to keep enough coverage or maintain some. As far as the MU differences go, you don't have to run these trials again. Hence, you don't have added MUs or more time on the floor. So you can see the percent differences with these. As far as guidelines goes, these are some of the numbers that I like to use in the clinic. As far as PTV targets, -25 or uppers 25. I try to keep numbers that I could help memorize or use some type of base 10. OAR series structures such as brainstem or spinal cord, optic nerves, like to use either 10 or 15. And the parallel structures such as submandibular glands, rectum, parotids. 0.3 is a good number to help squeeze those, even 0.5. The magic number that helped optimize the best for me without having to use one was 0.7. It's just trying to force the optimizer to work a little harder. These are some of the dose optimization limits that I like to start off with, but eventually you'll have much lower dose or something near there. So you don't have to make such a drastic jump, but this is just guidelines that work well within my clinic. Just wanted to thank you for your time listening to my presentation, and look forward to hearing some questions. Thank you very much.
Hi, everybody. I'm here to answer some of the questions that were given to me regarding my presentation on GEUD. The first one was asking, do I use it for all types of planning? And I definitely use it for IMRT planning, GYN, prostate, brain, not too much on lung. But yes, for those type of cases, I do use GEUD. It helps out with the bladder, the rectum, trying to spare the optic nerve, so max point doses or optic chiasm, lacrimal glands. These are the sometimes where I would use GEUD. As far as cases that I try not to use, it's during lung. Reason being is it does look great during optimization. However, once it gets calculated and it finalizes, the numbers that I put in and entered into the program don't necessarily equate to what I wanted to accomplish. So it's still a work in progress, and I'm trying to get the numbers that jive, work well with the system. But hopefully we will get something going later on in the future. On slide 18, I had, from my prior presentation, I had a slide where it showed that a GEUD of 1 in the parotids, and then it was changed to 0.7. The reason being is that when you start optimization with the GED of 1, it defaults to that, and it kind of matches with the mean dose. So you're not really challenging the system. I was trying to look for numbers that optimized, which can help with the planning. And I was using from 0.5, 0.7, 0.3, even 3 to help push the parotids doses or the submandibular glands without compromising the PTV coverage. I end up liking 0.7 and 0.3, particularly because it helps me squeeze the 20 gray line or the lower isodose curves or the 30% of the total value dose to whatever you're optimizing to. So 0.3 is my sweet spot. 0.7 is a nice optimal range. I still use 0.3 or 0.5 for if I was treating a prostate and I'm trying to watch the doses around the rectum and bladder. So those are the numbers that I like using. How much time do I spend using GUD? Well, I'll say that it saves a lot of time, especially when you have a large caseload. Especially in our institutions, it gets pretty busy, pretty hectic. So you wanted something that's it's not really necessarily templated, but it just offers a starting point because you want to still use these numbers and you're still trying to push yourself to get the best plan possible. It does save some time. I can't really put a number or like to put a number on it, but I could do a multiple head and neck if that's the case using these GUDs. The good thing about it is that you don't have to create so many upper values during your optimization. I could put 3 or 4 and it will still get the same job done. So that's why I like using this method. So hopefully I'll take time for any more questions down the road, and talk to everybody later. Take care.